Good evening, everyone. A warm welcome to all our esteemed attendees joining us today for this insightful session on the topic on the age, case based insight into identifying high risk coronary patients. I am Arpita from the IGCP group, and I am honored to be your moderator for this session. It's an absolute privilege to host this webinar featuring Dr. C.B. Keshavamurthy sir, an eminent cardiologist with vast experience in managing complex cardiovascular cases. As a consultant cardiologist at Manipal Hospital, Mysore, Dr. Keshavamurthy has been at the forefront of advancing cardiac care, and today he will guide us through real case scenarios to help us better identify and manage high risk coronary patients. So, with this very short introduction of the topic and sir, now I would request sir to please start with this topic. Over to you, sir.
Thank you very much for the kind introduction. And dear friends, I am happy to be here to share a few thoughts on how to manage a complex vascular case. At the outset, I thank IGCP for this opportunity to interact with you all and share a few thoughts which are useful to us in day to day practice. This format of discussing interesting cases is very important because it gives practical insights rather than a lot of theoretical knowledge. What happens in an individual patient is important to us so that we can realize we can quickly take the correct steps to give patients good outcomes. We all know that vascular patients, especially the cardiovascular patients, are always on an edge. They are walking on a tightrope. A little bit of a small event, a small bleeding event, or a thrombotic event, or a small stroke, or an MI can simply tilt the balance and cause a fatal outcome for many of these patients. So, since they are walking on the edge, we have to be especially careful with their medication, with their advice, with their counseling about compliance, with their diagnosis, which has to be perfect to anticipate what kind of events or where this patient's trajectory is headed. That will give us a good hold on how to control these patients' outcomes to some extent, at least in what we can. So, today I am trying to present a complex vascular patient, complex in different ways. I'll show you how complex it is and try to understand how we treated this patient for better outcomes. So, what do we mean by a high risk vascular patient? Patient who has recurrent vascular events. We all know that when we treat a vascular patient, about 80-90% of them they do extremely well. They are compliant to their medication. They have one event and they are fine for the rest of the time. However, about 10 to 20% of the patients have recurrent vascular events, maybe a myocardial infarction followed by a stroke or a peripheral vascular disease or whatever, renal artery stenosis, whatever kind of vascular event. So if they have recurrent vascular event, patient becomes a high risk vascular patient. Some patients have a very aggressive course of vascular disease. What do we mean by aggressive course? The atherosclerosis process is itself very aggressive. We treat them with a bypass surgery or an angioplasty, and a few months later or a year later, patient comes back with another coronary event or a cerebrovascular event or a peripheral event. So atherosclerosis is progressing very aggressively. So these patients are likely to have more events and a shorter lifespan. Polyvascular disease, as defined by presence of atherosclerotic disease in multiple territories like coronary artery disease, cerebrovascular disease, or peripheral vascular disease. These are typical polyvascular patients. We call them as vasculopaths. They have disease everywhere in the vascular territory, and the disease keeps on manifesting in different territories. As we treat one event, patient develops another event. Patient develops a peripheral vascular disease. Patient needs to have an amputation. So these are the kind of things patients who are called as polyvascular disease patients. Premature onset of vascular disease, when patients have atherosclerosis manifestations below the age of 40 years, which is quite common in our country, it is likely to be aggressive and shorten the lifespan. When patients have multiple risk factors, including family history of vascular disease, diabetes, hypertension, multiplicity of risk factors is again very common in our country. And super added to that, many of our male patients are smokers, which adds to the risk abundantly and causes events in a very young age, events at a very young age. So high risk subsets are also defined as age greater than 75 years. When you have patients at extremes of age, that is the older patients as well as the younger patients, both are at high risk. Diabetic patients are always at a higher risk, whether they have coronary artery disease or not, they become coronary artery disease equivalent. And whatever category, whatever subgroups you take, diabetic patients always fare worse than their non-diabetic counterparts, whether it is heart attacks, peripheral vascular disease, strokes, or even just on a regular follow-up patients, they fare worse than their colleagues without diabetes. If patients have chronic kidney disease somehow seems to accelerate the atherosclerosis, and not only that, about 85% of patients with chronic kidney disease die of a vascular event and not from the kidney disease alone. Women after the age of menopause seem to have accelerated disease and actually fare worse than men in terms of heart attack mortality, post intervention mortality, especially the diabetic women subset, which are who are at extremely high risk of vascular events. When patients have severe left ventricular dysfunction, this itself is an independent predictor of mortality at 1 year, 2 years, even at the long term. When a patient's left ventricular dysfunction sets in, they always have a downhill course. So these are the patients where you have to be extremely careful. Generally, when we see a vascular patient, we are careful with respect to control of risk factors and various other things. But when you see patients in these high risk categories, you have to be doubly careful. So, what are the patient factors? Many of the times we would have done our best. We would have done the best of surgery or intervention, put the best type of stents available, given them the best medicines. But there are some patient-related factors which lead to adverse outcomes, like poor follow-up. One of the important categories I would say is that a patient who comes in at one event and he doesn't follow up, he comes at the next event only. That is the one such patient which I am presenting today. Each time this patient is presenting only with an event, either a peripheral vascular event or a heart attack or a stroke, and sequentially in between there are no follow-ups at all. So this makes the patient a very poor follow-up patient, in that their compliance is not checked. What is happening in between the visits to their lipid profile or kidney function or blood pressure or even simple things like blood sugar, how is the patient compliant with the medicines that have been given? This is not under our control at all. So poor follow-up is one of the worst factors which indicates adverse prognosis. Low awareness about disease, very common again in our country, because people think that a heart attack is like any other disease, and if you take some medicines it is cured and you can stop all the medicines. Many patients, even today with so much of knowledge across the social media, people still come back and follow up a year or 2 years later after a heart attack, having stopped all the medicines. They say this was what was prescribed for 1 month and then told to follow up. I didn't come, I was fine, so I stopped all the medicine. This kind of things is seen in everyday practice. So this is about the low awareness which we have to seriously work on. The lower socioeconomic status, apart from the financial reasons and lack of follow up, they have to work, they have to labor every day for their living. So they may not concentrate much on their health and well-being. So that is another adverse risk factor. Poor healthcare coverage. Many of the places may not have access to healthcare. They may not have access to a good facility where adequate counseling, adequate medicines are available, specialists are there to see the patient. So this poor health care coverage is another important factor in a vast country like ours. Non-compliance to therapy advice. Simply, if we see the OPD compliance of patients, how they are taking their medication, how they are doing their tests and following their dietary advice, it's very, very dismal. It's only about 30% if you see, even in the best of centers, in the city centers, in the so-called tertiary care hospitals, despite so much of effort on part of the consultants and the hospitals and the dietitians and the entire team, the complete compliance to therapy is very, very dismal. Only about a fourth of patients actually take their full complement of medicines. Either they are partially taking, they have dropped off some medicines which they think are unnecessary, they are non-compliant with dietary practices, they have started smoking again, they have not done their blood tests at all for several months together. So these are all the type of non-compliances which you see, which actually contributes to worse outcomes. So non-compliance to medication and therapy advice is a very important part which we have to work on in these high-risk vascular patients. So high-risk subsets need special attention. Why do they require special attention? Because obviously they will suffer from higher mortality. Because of their high risk, they develop events, their lifespan is shorter, Many of them with peripheral vascular disease, for example, their 2 year mortality is like 60%. So many of them are dead or have an amputation event or a cerebrovascular event, and quality of life is significantly affected. These patients have also poorly controlled risk factors. There is a lot of scope for improving the control of risk factors. There has to be special attention to counseling these patients, because many times it is not just a socioeconomic issue. It may be an issue of understanding the disease. It may be an issue of lack of awareness of the patient as well as the near ones. If you tell a close attendant that you have to pay attention to the compliance of medicines, then the compliance, there is a possibility that the compliance will improve. If you counsel the wife or the partner or somebody who cooks about the details of the patient's diet, this may help the patient to be more compliant with what he eats. So these are all some smaller things which we can pay attention while counseling. Reinforcement and special measures to check compliance. In every OPD visit, we have a counselor or somebody who is auditing our prescriptions in our hospital, especially the clinical pharmacy students who are there, or interns who are recurrently checking and counseling patients. But many of the centers may not have that kind of facility for reinforcement, but it definitely helps if you have one such measure instead of just handing out a printed prescription and sending away the patient. If somebody reinforces that these are the medicines to be taken, this is the regularity of medicine, this is the follow-up at which you have to come, that may help the patient compliance. So I'm now going to present an illustrative case study of a 62-year-old lady who is diabetic. Actually, she is right now in the hospital, admitted with some other event, a fever event rather than a vascular event. But I will describe what are her high-risk factors. Diabetic, polyvascular disease. She had a coronary event twice, peripheral vascular disease in the past with a partial amputation of two toes, and a past CVA from which she recovered. She has had recurrent vascular events from 2016 to 2019 and 2024. We have done PTC and stenting and non-healing foot ulcer, as I mentioned, partially treated, healed after peripheral angioplasty after a couple of amputations. So this is a very high risk subset. Like I said, a female, diabetic, small body weight, somewhat fragile, very erratic follow. She comes only when there is an event. The last year thing appearance was for a peripheral vascular event where where she had a non-healing ulcer of the foot, underwent peripheral angioplasty. After that, the foot healed with two toes being removed. And after that, again, she stopped all cardiac medication several months ago, saying that I'll take only diabetes medicine and hypertension medicine. Poor sugar control. When she came this time, her HbA1c was 15.2, not the HB, it is a HbA1c. And left ventricular dysfunction, of course, is another independent risk factor. So on angiogram, she had patent stents. She had new stenosis in multiple areas, as anticipated. Very non-compliant with medication, especially the statins and the antiplatelets. She had several new stenosis. Patient was advised bypass surgery, but she is fragile and a very poor candidate for surgery because their vessel quality is not good because of the polyvascular disease, prior stroke, peripheral vascular disease, mild increase in creatinine. Therefore, we counsel this patient for a limited angioplasty, whereby to reduce the complications of surgery, this was her coronary picture. LAD had an ostial stenosis. We studied with a fractional flow reserve, and since it was not significant, what would have been a complex left main bifurcation stenting became only a circumflex artery treatment. So FFR was negative, therefore we avoided stenting the left main to LAD. So the left circumflex artery had a severe ostial stenosis, which we put a drug-eluting balloon. We totally avoided a stent because we know this patient's dual antiplatelet compliance. If we put a stent in the left main into the circumflex and patient doesn't take her antiplatelet therapy properly, there could be a fatal thrombotic event. So that was the plan. So we put a drug-eluting balloon to avoid additional metal, and whereby we had a good result. And patient symptoms were relieved. Patient was doing well till she got admitted. Again, she defaulted on follow-up. She had to come after 1 month after angioplasty, but she never turned up. She is now admitted with some kind of a tropical fever in the hospital for the last 2 3 days. So the intervention was simplified rather than doing a very complex bifurcation stenting with multiple stents. To avoid the risk of stent thrombosis, we just relieved the patient's symptoms by doing a simple plain balloon angioplasty with a drug-eluting stent. This was the lesion. The LED lesion was looking more in other views. So we had put a FFR wire there, which came as negative. That means there is no physiologically significant stenosis in the LAD. But this is the circumflex ostial stenosis, which is very severe. So we put a drug-eluting balloon here from the left main into the circumflex. There is also a branch, large OM branch coming up there. So this is a drug-eluting balloon whereby the drug is coated with a polymer and you inflate the balloon at that site for about 2 minutes, whereby the drug elutes into the endothelium and thereby prevents any restenosis. So we initially prepare the vessel by doing a cutting balloon or a regular balloon angioplasty and optimize the lesion, and then put a drug-eluting balloon. Many of the centers do use imaging, but in this case we didn't use any kind of imaging. So, how do you mitigate the long term risk of this patient? Of course, we have somehow escaped with what we think is a simple and optimal procedure for this patient. But how do we mitigate the long term risk? She's not going to come for follow up, she's not going to control her risk factors. So, intensive counseling about lifestyle changes, and the longevity benefits of change in lifestyle alone, the benefits of lifestyle uh, modifications like appropriate diet, regular exercise, and follow ups was reinforced. Reinforced medication advice and caregivers were resensitized, especially the husband, who is also a cardiac patient. And we this time we recommended supervised medication administration and regular follow up. So this was what was advised so that the patient outcomes would be better. In our mind, we thought this will be better. So we did get her diabetes down to a target of 7. She was started on insulin with home glucose monitoring and intense diet control. Hypertension was controlled to a target of 130/80, which is currently okay. Her blood pressure is now okay. Patient was on beta blockers. We added an angiotensin receptor blocker. I think angiotensin receptor blocker is the first choice of drug for a diabetic patient, especially this subset of high risk vascular patients. And of course, because she has a cardiac history and LV dysfunction, she was on beta blockers. Each of these points is important. That's why I have mentioned all these in the how to manage the high risk vascular patient. The targets of blood pressure, the targets of various therapies, what kind of drugs to use. Take here, for example, our dyslipidemia or LDL target is less than 55 because of the high risk vascular events and polyvascular disease. Maybe lowering LDL even lower may be beneficial for this patient, which was achieved with high dose statin and ezetimibe. Of course, we offered her evolocumab, but she didn't agree to take that. Her thrombotic risk we have mitigated with dual antiplatelet therapy now with ticagrelor and aspirin. And certainly at follow-up, once we go to a single antiplatelet stage, she will be on dual pathway inhibition. We have seen in the COMPASS trial patients that patients who have polyvascular disease do well with a single antiplatelet and rivaroxaban at 2.5 milligram twice a day. This is dose specific as well as molecule specific. So those patients who have, say, a myocardial event and a cerebrovascular event or a myocardial event with peripheral vascular disease, at follow-up, once you have finished that a mandatory period of say 9 months or 1 year for dual antiplatelets, these patients go on aspirin with rivaroxaban at a lower dosage, 2.5 mg twice a day. The pharmacokinetics of this dosage is important. So this is the dose that has been recommended from the COMPASS trial. So that is the dyslipidemia target hydrostatins. In certain cases, we have used evolocumab, and now inclisiran is also available. In a few patients, we have advised, but only one of our patients has so far taken the injection of inclisiran. Especially in my personal opinion, when patient has an acute event, there is inflammation, there is thrombosis, everything is on fire. The coronaries are on fire, the vascular tree is on fire. To cool that, in that period, intense therapy of LDL, intense lipid lowering therapy is important. And these are the patients who benefit, who have a maximum benefit with respect to not only reducing the LDL to good numbers, but also reducing the risk of future events. So that you have to keep in mind. So thrombotic risk, as we already discussed, dual antiplatelet therapy and dual pathway inhibition. Inflammation has been coming up and down, and there are several very strong studies. We are quite happy to use colchicine in acute myocardial infarction and even in acute stroke patients. But of late, there are a couple of negative studies which have come in and poured cold water on all the hot news. But we still continue to use colchicine in low dose, zero point 0.5 milligram twice a day for about a month in acute MI patients, as there is some reduction in the recurrent events. So, in summary, what do we do and how do we treat a high risk patient? You have to properly assess them and understand. You can quickly understand by your initial conversation with the patient itself, you will come to know what kind of patient this is going to be. Are they compliant? Are they receptive to what you are saying? Are they really listening? Are they on regular follow up? Is there a good element of non compliance? All these things are you can intuitively understand over a period of years when you see patients. Do the appropriate investigations. Very minimalistic approach to intervention, because you may do an extensively beautiful, successful image guided procedure. But if the patient doesn't take the dual antiplatelets, they'll always come back with a restenosis or a thrombotic event, which might sometimes be fatal. So, approach with an open mind on how this patient is going to take the medication and do the appropriate and very minimal kind of intervention. Risk factor recognition and mitigation extremely important. I cannot overemphasize on that. Careful attention to residual risks. Sometimes what happens at follow-up, patients continue to have high HbA1c, high LDL. We tend to think already we have topped out on the doses of drugs, so let us go slow and things like that. But this is what leads to future events. We always stick to the target. Sometimes we think BP of 150/90 is okay or 140/90 is okay. But for a diabetic patient or a CKD patient or a cardiac patient, it's better to reduce it to the appropriate levels. And close follow up and monitoring will help a large number of these patients. Like I said in the beginning, counseling, the caregivers especially, and how impactful our therapy is on prolongation of life, that and also the quality of life, that will certainly influence the patient and the caregivers to have appropriate compliance and follow. So thank you all for attention. I hope this was a interesting format of discussing few cases. We'll come back with more interesting cases. If you have any questions related to this particular presentation, you can now go ahead and ask or put it in the chat box, which I can read and answer.
Right, sir. Thank you, sir. Thank you so much for such an enlightening talk. Shall I proceed with the questions? Sir, shall I proceed with the questions? Hello, sir. Am I audible?
Arpita, any questions in the chat box?
Sir, am I audible to you? Hello, sir. Am I audible? Just a minute, sir. 1 minute.
Are you able to hear me?
Sir, am I audible now?
Yeah. Now we are audible. Yeah.
Oh, okay, okay, sir. So there
Any
was some
questions in
issue.
the
You
chat
were not
box?
able to hear me. Yes, yes, sir. There are questions.
Yeah.
What are the most often missed clinical signs that indicate a patient is at high risk for coronary events?
For the common clinical signs are of premature atherosclerosis. I would say on clinical examination, you can see atheromatous changes in the cornea, you can see skin changes of fat deposition. You can just feel for the pulses if there is a missing pulse that indicates an atherosclerotic disease in patients above the age of 50 years. A simple clinical examination can give you definite clues about premature atherosclerosis.
Right, sir. Sir, moving on to the next question. With advancement in cardiac imaging and biomarkers, how do you see risk stratification evolving in the next few years?
Yeah, there has been a very significant improvement in availability and extensive use of cardiobiomarkers, which are especially useful, especially the inflammatory markers like HSCRP and the troponins have kind of revolutionized the diagnosis and treatment of vascular diseases in general. If you have an inflammatory biomarker, it's a very important prognostic sign and also indicator of future events. So, if patient has high inflammatory markers, you have to be extremely careful. The second thing is imaging. Imaging has completely transformed the way we look at coronary artery disease, because we have a close look at the intracoronary tree. Intracoronary imaging gives us an idea of vulnerable plaques. We are now at a stage where we are treating the vulnerable plaques using physiology, combination of ischemia, anatomy, and coronary angiography, and we are getting to as near as possible to a perfect angioplasty or a precise angioplasty with the use of imaging.
Right, sir. One more question. So, in real world practice, what are the biggest challenges in implementing aggressive preventive strategies for high risk coronary patients?
Yeah, in real world practice, like I mentioned in the talk, the most important and challenging factors are from the patient side because we have no limitations with respect to the kind of wonderful drugs we have, the statins, the non statin therapies that are available. But the most resistant thing is from the patient side, the compliance. I would put compliance as the number one factor. Patients, even the patients who say that they are compliant, they are only partially compliant. They are not taking the full prescription, full medication advice, full diet advice. They're not following the exercise advice. Something is missing in these patients. So I would say that compliance is one thing which you have to look at if you have to overcome the challenge of recurrent vascular events.
Yes, so you have already mentioned that once they feel they are okay, they stop taking medications. This is
Yes,
what generally patients tend to do.
yeah,
Right, sir. Sir, for patients with multiple comorbidities, how do you balance the risk and benefit of intensive lipid lowering and antiplatelet therapy?
yeah. For patients with multiple comorbidities, you assess their bleeding risk as well as their thrombotic risk. If you consider the bleeding risk very high, like in the elderly patients and age above 75, altered renal function, small body weight, if you think that bleeding risk is high, then go a little bit easier on the dual antiplatelets. Maybe consider a single antiplatelet therapy early, and but with statins there is no compromise. You give moderate to high intensity statin therapy, get their lipid levels to targets. So this is how I would think of a multiple comorbidities patient, because they are very high risk. Their risk of events is about 20% in the next 5 years. So better to go very hard on the comorbidities, try to control as many of them as possible.
Right, sir. So one last question. That is, so if you can share a short case where an unconventional approach helped identify or manage a high-risk coronary patient effectively.
Yeah, this case which I presented is itself an example of a somewhat unconventional approach, because this patient had gone to many centers for advice, and one of the centers they had advised a bypass surgery. So when we advise the patient only angioplasty of the circumflex with a fractional flow reserve of the LAD, the patient as well as the attendants were surprised why not surgery. But having considered all the factors, this was kind of an unconventional advice. In this case, it worked well.
Right, sir. So with this, I would like to conclude the session. But before that, sir, heartfelt thank you from the IGCP team for putting up your effort for the presentation and for answering all the questions from the audience. So thank you so much, sir, and thanks to all the audience for joining in, for putting up their questions and making it a successful session. Thank you so much, sir, once again.
Thank you. Thanks to all the participants, and I hope it
Thank you.
was a good learning session. We'll
Yes,
continue with
definitely.
case presentation type of case presentations only. They're more interesting.
Right,
And
right, sir. They are more interesting. Yeah. Thank you. Thank you so much, sir.